we'd like to spend the last hour of the symposium with our Ask the Experts panel. And so the way that this works is you have been providing questions throughout the day and left them in a little basket up front. And so I'll be reading out some of these questions and directing them to our panelists. So please join me in welcoming our distinguished panel. So we're just going to open it up to some of the questions that you provided us on these cards today. And the first one is for Dr. Geschwin. And this relates to, it's a female attendee. She wanted to give you her family history. She has a paternal grandfather and an uncle with ASD. Both of her brothers have ASD, and her son has ASD. And she'd like you to please discuss the gender differences in heritability and expression of ASD.
So it's a complicated question. But I'll do my best. So what we know is that there's a 4-to-1 boy-to-girl ratio. We know very little about why that is. In your family, clearly there's a non-random clustering of autism spectrum, and that could be due to a dominant Mendelian kind of gene or just a clustering of genes, and be a very interesting study for genetic analysis, But, getting specifically to the girl question, the data out there suggests that so there are two, I'll just dichotomize two major possibilities. One is that it's something that's related to boys that boys would get and girls wouldn't. So X chromosome mutations. Because boys only get one copy, they get it from their mother. The girls have 2 copies. You can imagine if you inactivate a gene on the X chromosome, the boys lost that gene. Hence Duchenne muscular dystrophy in boys, hence Fragile X in boys, not in girls, because their other chromosome, they have 2 X chromosomes, can make up for that lack. And so people have looked, and other than some of these rare conditions like Fragile X, the X chromosome can't explain the X chromosome genes overall so far can't explain the boy predominance. So then the question is, what does? And it does look like there may be different risk factors for boys and girls in some different genetic risk factors. Those aren't well delineated, but there's some genes that may have a different effect in boys and girls, and the question is why. And so our main other hypothesis is that girls are somehow protected from having autism. It's not like boys are more susceptible, it's actually that girls are protected. And the way to test that is to ask, are there more severe mutations that have to occur in girls with autism? And so far, almost every study that's looked at that has found, yes, that's the case. That the girls have a higher prevalence of really bad gene inactivating, kind of what I call hammer mutations, things that really knock out a gene. It doesn't mean their autism is going to be more severe. It just means to get a diagnosis, the underlying genetic defect is not something that their nervous system can buffer. It's like a big bad mutation. And so it's this thought of buffering, that the girls' nervous system and development somehow allows them to buffer. Angelica Ronald in the United Kingdom and her colleagues have access to very large twin studies, and they've looked at this same question using the twins, and they find a very similar answer, that there's a girl, it's most consistent with a female protective effect as the major effect that one can pick up. It doesn't matter, it doesn't mean that in an individual case somebody may not have Fragile X, because we know that Fragile X contributes, and that's going to cause autism in boys. But actually, if you look at severe intellectual disability, so children who have IQs less than 70 and who have autism, the male to female ratio is 1. So it's not those big, those mutations are on the X chromosome, that these X chromosome genes are causing that. So it's a great mystery, and because of that, me and Susan and Morella are part of a network that includes the folks at Yale, the folks in Seattle, where we're studying girls and trying to look at their neurobiology. maybe up to 200 girls with autism. And and controls, doing imaging, doing genetics, all the cognitive testing to try to characterize and understand how are girls like boys and not like boys, and do we see different brain systems activated? Maybe, these things that Morella was showing you, are those kind of patterns of connectivity and activation to different stimuli and situations different in boys and girls. So it's going to be pretty informative. It's the first kind of study like that that's ever been done. So I would say that in 3 to 4 years, we'll hopefully have some answers, and I could actually come up here and we'll show you pictures of what this actually looks like. That will be a huge step forward in understanding the boy and girl risk.
Okay, well, thank you. The next question I think might be good for either Amanda or Ted, perhaps. The question is, what are your recommendations for cognitive measures when assessing children with limited language that have difficulty attending to the nonverbal gestural nature of nonverbal intelligence tests?
So that's a very tricky question. In research, with young children, we tend to use the Mullen scales of early learning, but that loads equally on kind of nonverbal and verbal ability. In some of our research with our more minimally verbal population, we've been using the lighter, which tends to take the verbal demand off of the tester, and it really loads more on nonverbal performance. So that's something we use. We also use a lot more language sampling and more naturalistic behavioral observation to supplement these standardized measures of cognition, basically so that we can say more than just what's reflected on an IQ test, because we know that's only a piece of the story here, and it just informs one piece of intervention or what we know about that child. So we really encourage multiple measures, especially for children who are minimally verbal or nonverbal.
I think that conceptually there's a really interesting piece to the question, because it's just to reiterate. No, not at all. I think that your answer is great. It's very difficult to find a measure that gets at intelligence in somebody. I mean, the wording is that have someone who has difficulty attending to the nonverbal gestural nature of nonverbal intelligence tests. Attention is a huge component of intelligence, so that when attention is constrained, limited, it's going to, I think that probably what's going to happen is you're going to get an underestimate of somebody's abilities. And so what you might do, as Dr. Goldsworth is suggesting, is you might get an informal measure of their attention and how much time they spend on task, just as an explanation of the results that you're getting on measures, because I think you're pretty much always going to underestimate what they're capable of if they aren't attending. But it's confounded, attention and intelligence, I think, strongly.
I just want to add a concept there from behavioral neurology that, and I don't see babies or children from a cognitive standpoint, so I'm way out of line, but I thought I would add it, in that it would be great to take off on what Ted said, to be able to kind of scale the testing score that a child gets with respect to their level of attention as it's measured. Because we know from clinical work that if any patient, has low attention, I can't even assess any domain of their cognition if it's below a certain amount. It's always relative to how much they're attending to the task and attention and motivation. And so we can have a patient who has perfectly great language who does 0 on all the language tasks that I'm doing because they're just not attending to it, and that happens all the time. So this is an enormous problem in autism, in any child evaluation. And that question is whoever put that one in, I think that's the hardest question we've ever had in like 6 years, because it's something that the field of assessment across autism, across a lot of things, really hasn't dealt with. I think the only time they ever do that is with like a CPT or other tests when they're testing in ADHD.
And I would just add that, you know, from a clinical standpoint, this really speaks to why you really do need people who understand development and understand how to work with these minimally verbal children to do the testing. I mean, I'll see, you know, I'll see children in clinic who have had an assessment, you know, on the outside, and they look really, really low functioning across the board. And, you know, we might do testing here or somewhere else with people who are more developmentally minded, and the child might look a lot better. You know, and across, you know, across time points, of course, there's variability, but a lot of that has to do with just the amount of work that the examiner is actually doing with the child. So I would say for the clinicians in the room, you know, being aware of who did the testing and how it was done and what the child's attention and behavior were like during the testing is really important, because children can look very different across different settings. And like these guys in the clinic and with all the early intervention studies, I mean, these kids come in 3-4 times to finish their cognitive battery that might take an older, higher functioning child 2 hours. Another thing I would quickly say is that, you know, we're also doing work using other techniques to look at cognition and attention, and electrophysiology is one of those. But, you know, we're trying to find more clever ways maybe to look at certain domains like implicit learning, like attention and interest to faces, you know, other types of learning domains that we don't capture well behaviorally because the child is minimally verbal, because their attention is poor. So there are other sort of creative ways to get around that by looking at maybe EEG markers of learning. And so we're doing some of that work as well.
So this next question we could open up to the panel, but I'm guessing Shefali might be the best person to answer this because you have expertise in sleep disturbance in ASD. The question is, does use of melatonin need to be monitored by a psychiatrist, or can parents start a child based on a pharmacist recommended dosage?
Yeah, you know, melatonin is, as Jim talked about earlier in his talk, very effective and very well studied and relatively benign. So, and it's available over the counter. So the recommendation, there was a really nice, a couple of really nice papers written by the sleep committee of the Autism Treatment Network, published in Pediatrics, that provided guidelines for both screening and treatment for sleep disorders and autism. And of course, the first line intervention is behavioral, trying to change sleep routines and that sort of thing. But if you go to medications, melatonin is the first line recommendation, in that there's no specification that it should be monitored by a psychiatrist. So any provider can provide guidance on that. Again, you don't need a prescription, but our recommendation generally is to have at least your pediatrician know that the child is on the melatonin. And there's really standard dosing that's not even really weight-based. The standard is to start at 3 milligrams and to, you know, go up to about 6. Jim mentioned in his talk that the studies have gone up even higher than what clinicians often will provide or prescribe or recommend. And the reason it's good to go to a physician who kind of knows something about sleep is that you're making sure you're getting dosed appropriately. Because if you're on a dose that's non-therapeutic, like 1 milligram, and there's no effect, you know, is it really because the melatonin's not working or because you're not on the right dose? So it's good to have someone kind of supervising that.
Thank you. Let's go ahead and open this one up to the panel. So this question is, why do you think some children outgrow the ASD diagnosis? Is that related to too early of a diagnosis or effective intervention?
Yes.
I think we have to be careful about this as well.
Yeah.
So I just want to caution you that even some of the work, I know this came from my talk today, children can look very different at different developmental stages in their life. And so just to say that a child doesn't meet diagnostic criteria at a certain age range does not mean that they won't meet criteria again in their lifetime. And so I think that, you know, I want to be careful about that message that children can be, many people have used terms like recovered or cured, and I think we need to be careful about the way we use those terms in the community, because of the fact that, you know, a child may look very good with appropriate intensive early intervention, may look indistinguishable from their peers, and then may hit adolescence and really see considerable setbacks. And so I just, you know, want to put that out, that we need to really be concerned about that piece.
I think another point to add is that just because a child or an adult is not meeting diagnostic criteria doesn't mean that they're not experiencing challenges and difficulties in their environmental context. When we look at some of the adult literature, there are individuals who probably would not receive a diagnosis where they evaluated that day, but still have a history of difficulty maintaining a job or maintaining quality relationships. And so I think it's important not to, or just to remember that diagnostic label, again, doesn't necessarily map onto a person's day-to-day experience.
That being said, there is some nice work that I presented out of Deborah Fine's group, who has very carefully documented over time some cases of children who, do not meet full diagnostic criteria at the points that they're measuring. So, we have to kind of take this with a grain of salt and think about it within a larger developmental framework.
Okay, next question. I think this was covered in Timba's talk earlier this morning, but we'll just go ahead and kind of review. So the question is, how will services for a child with what was formerly Asperger's or on the cuff change as a result of the DSM-5?
Hopefully services won't change. So if a child who has a diagnosis of Asperger's, that diagnosis of Asperger's under DSM-4 criteria is folded into DSM-5 so that they'll now be considered to have autism spectrum disorder. At least, when we're thinking about diagnosis. We don't know yet what's going to happen when these individuals are in their school system or trying to apply for Social Security disability insurance and programs like that, because we don't yet know how these programs might adjust their definitions of disability. So I think it remains to be seen, but hopefully the work group did work very carefully to make sure that if you have an existing diagnosis of Asperger's, you still maintain a diagnosis of autism spectrum disorder.
I'm going to combine these two questions, these next, and just open it up to the panel. So the question is there any ongoing research at UCLA on alternative therapy for ASD, and what is your view on hyperbaric pressure oxygen therapy?
I mean, I think it brings up a sort of a bigger clinical question that many of us who diagnose and treat these children are asked, which is, you don't, yeah, sure, we don't have the perfect treatment for autism, right? So parents very legitimately go out and seek anything that might work. And my stance in general with the alternative / complementary treatments is, if it's not dangerous, then as long as there's some monitoring done, I am not adamantly opposed to it. Things like chelation, there's been deaths reported with chelation, so that's a big no-no. Hyperbaric oxygen, there's been significant injuries and things reported with that, and we don't have good evidence to support that there's any reason why it would be effective, so there's no real mechanism underlying it. The diet is another one. The gluten-free diet is one that we all see a lot and get asked about. That's one where, what I say to parents is, if it's not going to break your bank account and it's not going to make your child starve, then try it, because there are certainly children where their behavior calms because they're just getting less sugar, and it can be effective. And I've seen it from a pure anecdotal, this is not the researcher side of me, but from the clinical perspective, I have patients who have really benefited from being on the diet. So, why that is needs better studies, but if it doesn't harm the child or the parents, and there's, I don't think there's a problem with it. But it really leads to some important questions about, we're not often providing another alternative for a solution. We have some great treatment studies going on and good treatments for calming behaviors and those sorts of things. But I understand why parents go out and look for other options, but we have to be careful.
Yeah, and I'll just add, so there are kind of two categories. Those alternative therapies that actually have been studied and rigorously evaluated, and if they had passed that evaluation, they wouldn't be alternative anymore. They would have, and there are those that haven't been studied, and there are going to be a lot of those out there. And I guess I look at it this way: I'd be very careful, anybody, if what somebody's asking you to do is based on some kind of testimonial or some kind of, and that's what people used to do in the 1800s. Those guys going around. I mean, you see that, with a little. Doctors used to go around with like a little horse and buggy selling whatever it was, called snake oil. But, based on some testimonials, right? They'd have a testimonial from a patient who'd come up and said, I couldn't walk last week, and now I can walk. And, you know, so that kind of stuff has been going on for thousands of years and will continue to go on. And, you know, you have to just be a little careful if it sounds too good to be true in anything, whether it's investing or medicine. It is.
So the answer to part one of that question was implicit in their answers, but there are no studies going on at UCLA addressing alternative therapies.
There actually was one just recently that Jane Taviev-Asher did through the Help Group UCLA Autism Research Alliance, and she was looking at the positive impact of yoga for young children with ASD, kind of on the lower functioning ages. These are kids with intellectual disabilities, and it was a small pilot study, about 15 kids. And she found some really nice improvements in behaviors in the school setting. The study was conducted in the school setting. And so that's just some preliminary findings that will hopefully lead to more research in the future.
And previously there have been studies done. Sarah Spence, when she was here, did a number of them, including a kind of, you know, something that might not be called alternative, but at the time, you know, secretin, you know, and so, you know, when there are things that are out there that are, you know, kind of rise to some level, where they're reasonable to test, where there's enough evidence, and there's a you know, a way to do it, we will definitely do that. We're as eager to get things that work, and but we've just seen a lot of you know, bad outcomes when or you know, and so you know, you don't want to. You know, one bad outcome would be spending $10,000 and getting no response, right?
I've occasionally been asked whether it's feasible or not to not only diagnose autism, but say give recommendation for therapy based on an imaging scan. And apparently there are people somewhere in this country that have gotten their hands on an MRI scanner who are offering this kind of services, and again typically at a pretty high cost. Well, don't go for that, because we are not at that point. If not anything, I hope my talk has conveyed that we are not yet at the point where we can put an individual, a child or an infant in the scanner and with, you know, certainty make a diagnosis, or based on what we see, say this is the type of therapy that will work for you, that one will not work, and so on. So if anybody's promising that and asking for a lot of money, don't go for it.
All right, so the next question, I think, again, to the full panel, is anyone doing research regarding rates of ASD among in vitro fertilization?
So that's a great question. It's definitely increased. There have been several studies, and if Jenny Lowe were here, she's been working on that. She's somebody who's a research scientist in my lab. We haven't published these studies, but I'm aware of 3 that come to mind that have looked at this, and there are probably more. Here's the problem. Chicken and egg, so to speak. I hate to use a bad metaphor. But if you've been having problems having children and go to in vitro, the question is it the in vitro or the predisposing problems? And that's the issue that cannot be separated. It's totally confounded. We and other groups are studying some of the banks that provide sperm for in vitro fertilization, or the donor sperm, have noticed doing genetic counseling and stuff that they follow up what's happening, and they found that in very, very rare cases, but I mean very rare, but they're there, there'll be a single donor who has multiple autistic or intellectually disabled offspring. Of course, they stop using that donor the second they find that out, but that's why they monitor that, and we're working with some of those banks to recontact the parents or parent and the donor if we can, and actually do genetic testing to see if we can identify. Because if you have a dad, of course the dad is the sperm donor, and you have a mom, you have 9 moms who have gotten that donor sperm, and 6 or 7 of them have autistic or severe developmental disabilities. You are assuming that there's a big hammer genetic mutation that's in that man's sperm, and so that might be a way for us to discover some new mutations and that kind of thing as well. So that's definitely out there, but the difficulty, and I think it's about threefold increase. I really haven't looked at the literature in a while. Maybe somebody else knows. But there's definitely an increase with in vitro fertilization, but it is totally unknown whether that's causal. Right? It's seen, and is it because those folks were having difficulty anyway that would have, under other circumstances, led to an autistic child as well? So that cannot be dissociated from that.
Okay, next question. What is the influence of intellectual disability on the long-term outcome for ASDs where IQ remains below 70 even after years of behavioral therapy?
We all know those children who have that secondary diagnosis of an intellectual disability. And I would say in general, you know, their outcomes are fairly consistent with their level of severity of the intellectual disability over time. It's not to say that these children can't make enormous gains, because they do. I see it every day. But some of the treatment targets and objectives might be slightly different. So, for example, if we had a child with we actually see many children in our clinic and research who have intellectual disability who tend to be in more of our minimally verbal population. And we've been actually adapting some of our techniques to specifically work with that population and to augment their communication with assistive technology, so that we can actually empower these children to communicate through you know, an AAC device, and we found some really, really great outcomes in that domain. So we're really trying to think about how do we adapt our treatments to better serve this population who may have, you know, persistent difficulties in these domains across the treatment period.
I guess I would just add that's kind of the hope of our genetics, but we're not there yet. But where it's like, those may be kids who have very severe mutations. That's where the overlap of autism and intellectual disability is, and we think that, excuse me, eventually, you know, we'll identify mutations in a subset of those kids that, for which there's actually a medicine that's been shown to improve them. So I think that, but let me make one clear point. In no way do I think medicine is a panacea. I look at it as, I think a great metaphor is reading. If you want somebody to read and the light is off, you can't expect them to read, even if the facility is there. On the other hand, if you just turn the light on, which is the medicine, the metaphor, throw the book on the table and say, read, they're not going to read. So a lot of what we're trying to do in educating kids and going to school, and even social cognition, which is implicit, not taught, but still learned, there has to be some structure and some kind of cognitive behavioral therapy intervention. So the notion is the medicine could be the kind of thing, excuse me, just have a cough, that turns on the light, but we still have to really physically engage with the child or adult to learn and to improve behavior.
So this next question was sort of partially addressed in Jim McCracken's study or presentation earlier, but I'll open it up to the panel. So is there any study that combined behavioral and medical interventions to treat aggression, repetitive behaviors, and self-injury?
So one of the projects on our Autism Center of Excellence, Project 3 as we lovingly call it, is a study that's combining behavioral intervention with aripiprazole or Abilify targeting specifically minimally verbal children with autism. Now the primary outcome of that study is actually we have biomarkers, we have EEG outcomes in that study, but also language. The question is whether augmenting a behavioral intervention with medication further improves social communication function. But they are gathering, a lot of these kids, the study hasn't there aren't that many kids in the study yet, but many of these kids have a lot of aberrant behaviors and aggression because they, they're minimally verbal and they haven't all received great intervention prior to coming into the study. So it is, those data are being gathered. It's not the primary outcome or endpoint of the study, but it'll be something interesting to look at in those kids. There's a lot of comprehensive testing that gets done prior to. So.
It's actually the first of its kind, as far as I know, that's actually augmenting a psychopharm type of study with behavioral therapy.
In a placebo-controlled way like this,
So it's exciting.
In that the primary outcome measures are language and biomarkers, the behavioral component isn't really addressing self-injurious behaviors and aggression. So it's not exactly a yes to that question, but it's a great research designed to see how the medications augment the effects.
All right, so another question. If someone is diagnosed with autism spectrum disorder in their adulthood, is it still beneficial for them to attend a social skills intervention? I swear I didn't plant that at all. I didn't know. No, go ahead. Okay. Absolutely. Okay, so my specialty is in developing and testing evidence-based treatments for social skills and social behaviors in people with autism across the lifespan. And yes, absolutely, if they're struggling socially, then absolutely social skills training is warranted. The issue is that there aren't a lot of great interventions out there, unfortunately, for adults. There's really very few services, and of the services that are available, practically none are evidence-based. We do actually have a program at UCLA, I'm very proud to say, called Peers, and it's for young adults on the spectrum. It's also for adolescents, and we have a preschool program, but it is an evidence-based social skills program for young adults ages 18 to 28, and we do have some nice randomized control trial data that shows that it is effective. What's different about this intervention, though, is that we actually include parents and caregivers in the treatment as well to act as social coaches to their young adults outside of the treatment setting, because as we all probably know, a lot of young adults on the spectrum still are quite dependent, unfortunately, on their families and caregivers, and so they need that additional support. But yes, absolutely, if there's a young adult who's diagnosed maybe later in life and is struggling socially, absolutely treatment is warranted. Okay, anyone else want to comment on that?
Yeah, I'd like to add to that and just kind of provide an anecdote from my experiences in Michigan. But at UMac, we ran social groups for adults and teenagers and young children, but our adult group was different from some of the evidence-based models presented in the literature in that it was long-term. The average duration of group membership was actually about 4 years by the time I was there. And so we had kind of exhausted some of our evidence-based approaches, but what came out of that group was truly lasting friendships. And our adult group members, I can say without a doubt that they would all talk about how that group was one of the most important things that was going on in their life. And so I think absolutely being a part of a structured group or even creating your own informal group of anybody who's interested in that kind of social gathering and who might be empathetic to the difficulties that an adult is having, I think it's absolutely something that they should do.
Next question, who is the best neurologist at UCLA, Shefali, that could assist an adult with seizures that has ASD?
Someone with an adult with ASD?
An adult with ASD with the seizure disorder.
What do you think for adults? I mean, there's great pediatric.
There is not one that's the best, but it's actually the seizure treatment is one of the specialties. Just in general in adults. I'm trying to think of somebody who would, we're not as used, well, in adults with chronic seizure disorders, the behavioral aspect of that can be very, very severe. So they have quite a bit of experience in that, although it's not necessarily a lot of autism-specific experience. But if somebody wants to talk to me afterwards, I can give you a few names. Or is this for a general referral or for a specific person?
Specific person.
Okay, then let's just talk afterwards, and I can give you a few names.
Yeah, I can also. I mean, the pediatrics folks like to stick to peds, but if it's someone who has a significant developmental disability and has had epilepsy since childhood, we'll keep following them. So there's some really good pediatric epilepsy people.
Well, I'm afraid we are at the end of our hour, but before I hand the mic back to Susan Buchheimer, please just join me in thanking our distinguished panel.
And I'd like to thank all of you for joining us today, and we hope to see you again next year. Thanks very much.